Well, so I'm Tom Wally and I'm introducing this session today. So I'm a non-executive director in Luft and I'm one of 8 non-executive directors. And for those of you who don't quite know what a non-executive director does, our role is to bring an independent view to the board, to help ensure the highest standards of integrity, support the trust chair and the chief executive and all the executive directors in promoting the values, the culture of the trust, help decide our priorities and to manage risk and develop the strategy. So one of our roles is to challenge the executive in a very constructive way and to listen to the words of our governors and our members around what they and you think should be happening and to feed that back into policy. So I've sat on the board as a non-executive for just over a year now, and as you'll all know, it's been a fairly tempestuous year. My background is that I was a consultant physician in the old Royal as it was until I retired in 2018. So I've come back to the Luft board on behalf of the University of Liverpool, because Luft, of course, is a university hospital and the university has the privilege of being able to nominate a potential non-executive, which then has to be approved by the governors, and to try and make stronger links between the university and the hospital. So as a consultant physician on the Royal for many years, I was very conscious of what a crucial role palliative care brings to the care of patients and their families. Many of us will have deep memories of the loss of some of our loved ones, and it's really important that we manage the pain that the patients and the families experience during that time as well as we possibly can. And I'm delighted to say we've got a very active and strong palliative care team in Luft, and this group presented to the board it's about 2 months ago now, and we were really excited at what the work they were doing and where things can go in the future. So I'm delighted to introduce Dr. Julie Bellew and Fiona Murphy on behalf of the palliative care team, who are going to take us through the rest of this session. So over to you, Fiona and Julie.
Thanks, Tom. So I'm Julie Bellew. I'm the Clinical Director for Palliative and End-of-Life Care across Luft. And I'm joined today by Fiona Murphy, who is our Director of Nursing for Corporate Services, who's been heavily involved in the development of our end-of-life services. So it's lovely to be here and lovely to have the opportunity to talk to you and tell you what we're doing to improve end-of-life and bereavement care across Luft. Why is it such a priority for us? Well, it's a priority because we know that end-of-life patients spend a lot of time in hospital, and unfortunately around 50% of people die in hospital. Around 70% will have at least one admission into hospital in their last 3 months of life. And it's really, really important, therefore, that we get their journey right and that we help to support them and those close to them as best as we can to try and meet their wishes and improve their experience. There are a lot of challenges to delivering good end-of-life care in Liverpool. We've got high levels of deprivation in some areas, and we've also got patients who present quite late with quite advanced disease to the hospital, and so it's often, quite a short space of time that we have to get everything in place and get everything right to help support patients. But we've had a real opportunity with the merger of the acute trusts with Aintree and the Royal and Broad Green coming together. Last year we had the transfer of clinical services from Woodlands Hospice into Luft, and we've been working really hard with our community colleagues and our other partners such as Marie Curie Hospice in Liverpool to try and bring together a more integrated and united approach to palliative and end-of-life care. So this is really, it's something that's our real opportunity to start something new and to really start to improve our outcomes for patients approaching end of life. So we're here today to talk about our strategy and our vision. So I'll just move forward. So we've produced a 3-year strategy to help support what we want to achieve across end of life and bereavement care. And there's our vision on the screen as well, that we're trying to develop a person-centred approach to delivering integrated responsive end-of-life services across all settings. And our motto is that end-of-life care is everyone's business, and that's really critical. Whether it's a doctor, nurse, porter, domestic team, admin, everybody is involved in delivering care to patients approaching the end of their life. and those important to them. We estimate at any one time around a third of the patients in the hospital maybe in their last year of life. So it's really a core part of what the hospital's about, and that's why it's such a priority for us over the coming years to get this right. Our strategy is based around the North West model for life-limiting conditions, which has been a regional model that's developed over the last number of years. And previously we used to talk about that as being the last year of life, but we recognise with all of the increases and improvements with treatment for both cancer and non-cancer disease, that actually patients are living with a palliative condition now for sometimes many years, and it's really important that they get the right help and support and symptom control right from the point of diagnosis of a life-limiting condition all the way through until they approach the last days of their life and then into their bereavement. So the end-of-life care journey can be quite a long one for many people, and the key part of it is about thinking ahead and planning. If we want to meet patients' wishes, then we need to act early to find out what they want, to share information across different providers, both in the community and the hospital and the hospice, to try and get things set up and in place before a crisis hits. So a lot of the work that we're doing, yes, there's certainly focus on last days of life care, but palliative care is that whole patient journey for both the patient and for their family. And this is all about supporting people to live well in the last years of their life, with very much a focus on what's important to the patient, as well as the kind of clinical care element. So our strategy is split into 6 main work streams. Each work stream has an overarching commitment and then is broken down into different objectives that sit beneath that work stream, and we have wide members of the teams, both palliative care teams, but also our other clinical teams across the hospital, helping to support each of these objectives. So our first priority is probably the key one. So everything that we do focuses around patient and family experience. And it's really, really important that in the services that we develop and the care that we deliver, that it meets the needs of patients. So objectives within this work stream are around getting feedback and surveys from patients and their carers about what we're doing well, but also maybe what we're not doing so well, so that we can make positive improvements and learn from that. You know, we know that sometimes mistakes are made or care might not be optimal, but the only way we improve is by looking at that in detail and learning. So we're looking at all of the resources as well that we have available and facilities for both patients and carers, and making sure that those are readily available. And Fiona is going to talk a bit more about particularly some of the end-of-life resources for patients who are more imminently dying, what's available to them and their families within the hospital. But also it's making sure that we've got resources for staff and guidance and everything in place so that they know what they're doing and that they feel equipped to provide the most compassionate care that they can. Our second priority is around service integration. As I said, there's a lot of different services across Liverpool, and for the past few years we've been bringing all of our palliative care services across Liverpool and South Sefton together to form the integrated Mersey palliative care team, and that's a one team approach with a single point of access and referral into palliative care services to reduce a lot of the duplication and confusion about which aspect of the service a patient might need at any one time. So we now have 2 hubs in the city, one sitting at Woodlands Hospice and one sitting at Marie Curie Hospice, where all calls and advice all comes through those hubs, and we have the community, hospital and hospice staff sitting together, supported by a medical team, to deliver the right care to the patient by the right aspect of the service at the right time. And that's making huge improvements in how we deliver our services. So it's reducing the access time to medical appointments, for example, has dropped from over 2 weeks to within 24 hours. But also we're seeing some real improvements in terms of managing to support people to stay at home and to die in the place of their choosing. So despite the pandemic and the fact that more people have been coming into the hospital for lots of different reasons, we've actually seen a 14% reduction in the number of patients having to visit hospital in the last 3 months of their life, and that's quite an achievement given given the current climate and the demand on hospital services. And that's been about close working with our community teams so that they can access care at home, and that we can go out and provide the service where the patient needs it most. And we've been working to do that in hours, but also out of hours. So again, working with our colleagues in the community, district nurses, etc., to be able to get the right care at the right time. So there's still a lot more work that we're doing to improve the information sharing, the IT systems, and to develop that one team approach. But it's been a really exciting development. I think it's really making a difference to the patients of Liverpool. Our third priority is around workforce training, so it's making sure that all staff know what they need to know, and that we've got everything in place to do that. So we're looking at sort of basic education for all staff, but also then for those staff that are more committed to learning more about developing a sort of champion role that can help to improve care at ward level, and being able to track that and being able to demonstrate who needs support so we can target education at specific areas is a key part of this work stream. Transitions of care. So the reason we've got a work stream around transitions of care is because we often know that when patients move across boundaries between hospital and hospice and community, but also as they transition through their patient journey from an early point of diagnosis to last days of life, that's often where things can fall down and things can change more rapidly, and it's difficult sometimes to get things in place in a short space of time. So we've got two key work streams, working groups sitting in this work stream. One is around discharges and trying to coordinate our efforts to make sure that the discharge process from the hospital into the community is as safe and responsive as possible. And another work stream looking at advanced care planning, anticipatory clinical management planning, resuscitation, how we have those conversations, how we share information about that, and how we help patients to plan ahead into the future. So that's, again, quite an exciting lot of work that's happening around that. Our fifth priority is to ensure that we've got a really strong evidence base for what we're doing, and we are linked to the University of Liverpool on a number of projects as part of the International Collaborative for Best Care of the Dying Person, but also with projects around technology and palliative care, and some other work that we've been doing with other partners around head and neck cancer. There's lots happening, but we're really trying to build a research culture within our team and within the service so that we can really improve the care for our patients. And then our final priority is around end-of-life outcomes. So how do we measure what we're doing? How can we show that we're actually making a difference to our patients and their families? Well, we need to be monitoring what we're doing. We need to be benchmarking and auditing our performance so that we can see what areas we need to focus our efforts on, and to compare how we're doing to other hospitals, but also within our own local community. Are we achieving what we're setting out to achieve? So that's again a really important work stream, but already we're beginning to see real progress in terms of our outcomes. So I'm going to hand over to Fiona now, who's going to talk a little bit more around the Swan model of care and what that means for patients who are more imminently approaching the end of their life in the hospital setting. So over to you, Fiona.
Thank you, Julie. Good afternoon, everybody. Okay, so I have got several slides of which I'm going to share, but I'm only going to talk to a couple of them due to time constraints, and Julie's covered so much. So next slide, please. Why a swan? Why are we using the swan? So swan in Roman times means happy death. It is a evidence-based, realist evaluated model of care that is just about to be published. It's been published, the literature review has already gone out there into the public domain, and the research is just about to go into publication. The Swan model is used in around 70 hospitals nationally now, but the recommendation is that this is part of best practice. And what does Swan mean? So next slide, please. Swan means, is the patient believed to be entering in the dying phase of their life? And if so, we need to start the individual care plan. Are we sensitively communicating with the patient and those family members that are coming alongside them? Julie's already alluded to that end-of-life care is everybody's business, and are we actually stepping outside the box to facilitate what's important to the patient and those family members that are coming alongside them? And it is really important that everybody in the acute care setting, care homes, are actually involved in the delivery of quality end-of-life care. We also look at the needs of the patient. Are we meeting those needs, and are they being reviewed regularly and documented? I absolutely believe that end-of-life care is everybody's business. So we are working really closely with palliative care services, with the hospital services, with the quality improvement team, with our police colleagues across Merseyside, and with our coroners. And only this week we have now recruited 3 full-time Swan end-of-life care bereavement nurses and a part-time educator. We've got another 2 posts out to advert, so we will have a bereavement nurse on each hospital site to support the delivery of the softer things in regards to the end-of-life care delivery. One of the bereavement nurses will also be based in the coroner's office to work alongside our police and coroners colleagues, and they will also look after and care for the family of patients who have been relatives who've been victims of a suicide or a murder or mass fatalities that's happened across our city footprint. And it's about trying to create memories for patients and their families to support them in their ongoing grief journey. So when a patient's been identified at within their end-of-life care phase, it is really important that we try to demedicalise the environment of which they're living in. So it's working with our community partners such as the Girl Guides to make comfort packs to support families, and our previously bereaved families are doing a lot of knitting for us to create knitted blankets. So it's really trying to create a compassionate community. And I think that's really, really important. We think because we're dying in hospital that actually we can't make that a really good death from a memories perspective, but actually we know that you can. You know, it's okay for us to bring pets into hospital if that's the wish of the dying person and the family. It's okay to give mouth care with somebody's favourite flavour, and it might be Prosecco or Guinness or whatever that may be. It's okay for families to be involved in the delivery of that care. It's all right for nursing teams to offer families a hot meal when they've been sat next to the end of the bed. And fantastic facilities have opened at the Aintree site where families can go, walk away and have a shower and a hot meal. But ward staff are also allowed to give permission. It's about breaking rules that don't exist. A meal off the food trolley if they've seen that family have been there for any time. It's about the delivery of compassionate conversations and communications, ensuring that we really focus on what matters to me. I'm going to finish off with a poem that's been sent in from a family whose husband was dying. A beautiful moment. He struggled to breathe all through the night. She felt helpless, not knowing how to ease his fight. Then suddenly an angel in disguise said, "This is your time with him before he dies. You decide what's right for you. No one here can tell you what to do." She lay beside him in the bed, whispered words of love and tenderly stroked his head. His skin was smooth and warm and rosy. She held him tight, cuddled up comfy cosy. She lulled him to sleep with a soothing word and touch, knowing she gave comfort to the man that she loved so much. Exhausted too, she fell asleep as one by one the nurses came to peep. Then suddenly a miracle occurred. It may have been a touch, a word. In a beautiful moment, as she quietly cried, his breathing stopped and he contently died. Every single one of us are the they. We are all going to be, if we've not already been in the position of somebody that we love and care about dying. and it's about doing the small acts of kindness from everybody across our organisation to help make that experience the best it can possibly be, that sits beautifully and collaboratively along the palliative care services where symptom control is sorted and looked after appropriately. The Swan model also reaches out into our community deaths and our care homes, and so our aim is to make a compassionate community. Thank you.
So thank you very much, Julie and Fiona. So as I said, this was presented to the board about 2 months ago. We're very excited by the development of the Swan model and the prospects it offers for better care for our patients. And the key thing, the key word, if I was to draw one out of all you said, is the word compassion, and how we demonstrate that to our patients. And sometimes in a large organisation, we forget about that. And hopefully, thanks to the work of Julie and Fiona, we're refocusing ourselves on that. So open for questions or comments from anybody who'd like to ask questions. So I can't see any questions, Niamh. I don't know if you have any.
Okay, so I can see that there've been a few questions put into the question and answer section. So one of them is, how much say does a patient family have in regards to the patient's wishes? So Fiona, I don't know, do you want to start with that one?
So I think the first thing to say, it's really important that if we can get consent from the patient in the first instance of how much say they want their relatives to have, and some patients don't always want to have a big say. I think that conversation really matters to me and to our patients, and I think the majority of patients do want information and they do want their families to be involved. Just unfortunately sometimes we're afraid to ask those questions.
Yeah, I would certainly agree with that, and I think sometimes the needs of the patient can differ slightly from the needs of the family in terms of what they want to ask and what they want to know. So with the patient's permission, you know, we often actually have separate conversations with the family to give them the opportunity to share their own feelings and what's important to them. And then it's, you know, it's part of our job is to bring all of those wishes and worries and things together to try and get the right plan of care in place for the patient and their family that they'll all be happy with, because I think it's often a time of quite high emotional tension, isn't it, at times when somebody's particularly imminently dying, and you know it's important that we consider that wishes can be met wherever possible, but always with the needs you know, at the forefront of our mind as to what's safe and what's best for the whole situation.
Thank you. I can see the questions now. There's another one here then. Is there anything non-clinical staff can do to support the Swan model in a voluntary capacity?
So absolutely. So there's lots of things that we can do as a group and a community, if you like. So again, if you're a knitter, knitting blankets or hearts, or making little bags for jewellery or locks of hair, like I've already said, the Girl Guides are doing our comfort packs for families, and that is just such a fantastic, beautiful piece of work. And we also have end-of-life volunteers in our organisation that who are trained and educated via the palliative care specialist nursing team and our volunteers coordinator. So if that would be something that you would be interested in, or you know, please feel free to contact us and we can give you more information. You know, we say, don't we, our strapline is end of life care is everybody's business. But actually, it's not just hospital staff's business, it is everybody's business. So the more people that we get to contribute, the better and the more compassionate we'll be across the city. So thank you.
So can I ask a question, if I may, in here? So We often perhaps think that our colleagues working on wards are perhaps used to seeing patients dying, but it's often desperately upsetting for them too. And I wonder if you can talk a little bit about the support you can offer to our own colleagues.
So I think that that's part of our workforce training work stream, is actually around clinical supervision and support for staff, because we recognise, you know, for all groups of staff, not just the specialist teams, but actually it can be really difficult, especially in the current climate in the hospital where everything's so busy and everything's so rushed, to allow staff to be able to deliver the type of care they want to. And I think, you know, we have supported in the past conversations after the event with teams on the ward to talk about what's happened, to talk about what the challenges were, to talk about what went well, because I think sometimes we don't often always celebrate the successes that we have and the excellent care that is given. But having that opportunity to debrief, I think, is really, really important, and that's something that we're hoping to develop further, you know, with across all teams and services into the future.
And does that extend to, for instance, I mean, the kind of area I would think of perhaps being most traumatic, something like the death of a young person in the ED department, which is very traumatic to the staff there.
Yeah, absolutely. So just to build on that, the new Swan end-of-life care and bereavement nurses will be based on each site, and they will go to sudden unexpected deaths in our accident and emergency departments, and also pick up the care and support of the coroner's office staff, who also deal with really traumatic situations of sudden unexpected deaths. Envisage, and in other organisations, that the majority of the bereavement nurses' workload will be with our sudden unexpected deaths, because our expected death patients already have the expertise of the palliative care team, but it will be about us working in harmony so that actually everybody gets the support and the right care at the right time by the right people, and I think that's really, really important.
Thank you. So we've had a question about companionship. If people do not have family and friends to visit them and spend a lot of time alone, as ward staff may be too busy, what do we offer in that situation?
So this was the idea behind the development of the end-of-life companionship service. So that's our volunteer service. So we were really keen that, you know, it's not always possible for people to have friends and family present, and some people, you know, don't have people close by or around to come in, but we didn't want anybody to be left in a position where they were potentially dying alone. So that was the real push behind getting the service up and running. And while the companions do sit with people who don't have anybody, they also are really great at sitting with patients while family or friends have a break and some time off the ward to go and have a shower. As Fiona mentioned, we've got new fantastic facilities on the Aintree site, and we'll hopefully have something similar on the Royal site to offer a private space off the ward for families to have some downtime and to have a shower, to have something to eat and drink in a private space. So our volunteers help to man that space and to make sure that they support people that are using that area, but also to provide that companionship aspect to allow people to have time out.
Okay, thank you. Right, any more questions, anybody? I think we've probably come to the end of the questions then. So if so, it just remains for me then to thank Fiona and Julie very much today, and thank all of you for attending this, and we look forward to seeing you at many more of our virtual events, which I hope you'll find interesting. The program's been circulated, and thank you for coming today.
Thanks everybody. Bye-bye. Bye.
Bye.